Health in Governor Hickenlooper's office. And I'm really here to do a quick kickoff today, and then I'm going to turn it over to my colleague Ben Miller, and he's going to turn it then over to Steve to talk about all the exciting actuarial stuff. But what I think really just what I wanted to do, in addition to thank you for spending the time to either be on the call today or listen to the recording, is talk a little bit about how this project, the SIM project or State Innovation Model Project, really fits in with the governor's broader health agenda, and really note that it's a key priority of what we're trying to accomplish to make Colorado the healthiest state in the country. So some of you may be familiar with our health agenda, which we call the State of Health, but it's a document that we published just over a year ago that really addresses 4 dimensions of work that we work on as an administration with partners in the public and private sector, many of your organizations included. And those 4 dimensions, just very quickly, are first, promoting prevention and wellness, helping Coloradans to stay healthy and become healthier. Second, expanding coverage, access, and capacity, or what I call the ACA bucket. Third, improving health system integration and quality, ensuring that the systems that we have are functional and are there for Coloradans when they need to access care. And finally, enhancing value and strengthening sustainability, making sure that the investments that we make as a state, but also as a community in Colorado, are ones that will pay off over the long run and keep our health system sustainable, or really make it more sustainable. And I think really the value of SIM and the work that we're trying to do, and we hope that you will engage in with us, reaches across all 4 of those dimensions to really address a person-centered mode of care in which Coloradans can get both the behavioral and physical health care that they need, and that will help them become healthier overall. So again, thank you for your time and commitment to this. If you have any questions, please feel free to reach out to me. I will have our moderator put my email address in the little chat section on the recording. But thank you again, and I will turn it over to Ben.
Thanks, Catherine, and thanks again, everybody, for joining us today. This is going to be a lot of fun. We have one of the best in the business that's going to be talking us through some pretty intricate analyses that he has done. I'm going to allow Emma here in just a second to explain some of the rules of our webinar today, but I do want to let everybody know that you are in listen-only mode. This is a function that is somewhat of it's a good thing and it's a bad thing. It doesn't allow us just to instantaneously ask questions, but as Emma will tell you, we want you all to be involved and to ask questions to Steve as appropriate. So there will be a moment in time when I might just check in and see how people are doing. Steve might check in and see how people are doing. You can always put your questions or chat in the side, the right-hand column, for us to take a look at. So let me quickly introduce Steve, who I don't think by this point in time needs any introduction. Steve is one of those amazing, wonderful assets that we have here in the state of Colorado. He's a principal consulting actuary at Milliman and has done more work around some of the mental health and the primary care space than almost anyone that I know of. Steve is a force and someone that I'm happy to know and call a friend. So before we turn it over to Steve, let me give this back over to Emma, who's going to walk us through a few of our rules today.
Great. So just very quickly, you'll have a GoToWebinar control panel on the right-hand side of your screen, and you can use that to listen as with either your computer, microphone, and speakers, or your telephone number. And the telephone number to call in is at the bottom of the control panel. Like Ben said, we'll have questions throughout, but then also some time for questions at the end. And so to submit questions, you can type any questions you have in that question box towards the bottom of the control panel, or you can also raise your hand and we can unmute if you'd rather ask your question verbally. So that's it as far as how to use GoToWebinar. Steve, are you ready for me to pass control to you?
Yes, I am.
Okay, here you go.
Well, thank you, Catherine. Thank you, Ben, and thank you, Emma. I'm Steve Melek, and it was my pleasure to be asked to help the SIM management team and the innovation model development team to provide actuarial assistance in completing the required CMS template, which was a summary of the results of the innovation model, and as well to be involved with all of the worksheet, workbook, data projection development. And that's where really I'm going to spend my time talking today to help you understand the projections we did, the data we used, the various assumptions that were necessary for the development of the financial plan. And what you're looking at on the screen here right now was provided by CMS as the description of what they wanted for us to submit the state innovation model financial work. And you can see that there were two different parts that could be used. Part one was the model design applicant, and we did not do that because we were a part two model testing application. So I'm going to try to go slow enough so that the scrolling will work for everybody. But part two applicants had to fill out this financial plan with a variety of different tables. And for the actuaries and the financial people out there and for everybody else, it was typical actuarial metrics. There's annual utilization rates per thousand, average paid unit costs, per member per month costs, annual costs, and because there was a series of tables, Table 2 series was a series of requirements without the innovation plan. Table 3 requirements were with the innovation plan, and of course the differences between the two were providing the net change as a result of the innovation. And then tables 4A and B that are described were really the final net savings and the return on investment results. So you can see here, and I'm not going to spend much time at all on the government provided Excel model. There are the series of instructions, and part two was the instructions that we had to follow. And you can see that there was a narrative that was required to be provided with the appropriate tables, and I am just going to very briefly show that we did develop a narrative of the work that we did, and it was 24 pages long, but a lot of those pages included a series of tables showing all the assumptions we made. So we did complete that. And then the tables that were required all throughout the series, the Table 2 series, Table 3 series, and Table 4 series. I will be walking you through some of the results and telling you what we had to do in order to populate those tables. That really was the deliverable. It was the Excel file with all these tables populated, plus the narrative that went with them, and then that was the actuarial work. That was a piece of the overall SIM development that was completed by Ben and his colleagues and the whole SIM management team. So let me just show you one interesting thing in the government-provided tables here. And I guess it's a caution to always be careful when the government, state or federal or whomever provides a template in Excel with some pre-populated formulas. And it's interesting that their formulas do not always accurately reflect the instructions. So for example here, you can see the service categories that they required, starting with inpatient hospital, outpatient hospital, etc., as you go down the line. And there is a subtotal and a total after prescription drugs. But they make a note here that outpatient is the total for the category and emergency room is a subtotal of outpatient services. Well, look at this total formula that they provided, which is a sum of cells B6, 7, all the way through 20. What's wrong with that formula? Well, emergency room is a subset of outpatient hospital, so they're counting it twice in their formula by just summing them all up. And then what they neglect to do is add in prescription drugs in their total formula, and it should be really the subtotal, properly not double counting emergency services plus prescription drugs. So we, just as a precaution, always check their formulas with the instructions to make sure that the formulas are correct. And we got ours right, regardless of what the totals are here in the government template. So now I'm going to take you to the work we did, and just so you can see here in Table 2A, our total properly did not double count emergency services. It did take the subtotal of all the service categories and add in prescription drugs, so everyone's comfortable that we didn't mess up by using the government formula there. So our workbook turns out to be about 30 megabytes in size compared to the starting template, which was about 135 kilobytes. So there's really a lot here, and I want to be mindful to kind of go at a high level and show you all the things that were included in our work, including all the various places where we had to make a series of assumptions, because again, the template requires you to fill out several different years, and maybe Table 2A is a good place to start. You can see that their requirements are to take the population within the state of Colorado and to break it up into different cohorts in our projections. So for example, here we've got Medicaid and CHIP split between adult, child, duals, disabled and elderly without the duals. As we continue to scroll over, there's private or private and other, which is really the commercial insurance. And while the template asks for us to split individual from family members, the data that we had did not enable us to do that. So we just explained that we put all the commercial business under the individual column here and did not separate out families. And continuing to scroll over, because these cohorts are consistent to all the tables in the model. For Medicare, there are dual eligibles, then there's fee-for-service, which was non-duals, parts A and B only, and then Medicare Advantage Part C. Again here, we did not have the ability within our data to separate out Medicare Part C members only, so we included and described it as such. All the Medicare fee-for-service members were included together. We did not separate out Medicare Advantage, and I'll talk a little bit more about why all that happened. So you see the various cohorts that they set up within their model, and we did the best we could to follow those cohorts, but we could not do it perfectly. And then in the rows, as I was pointing out before, they take the total healthcare pie and separate it out into what I'll call major service category. And most of them make sense. There's inpatient hospital, outpatient hospital, including emergency room, professional services separated between primary and specialty care. They had a separate row for labs and x-rays, or I should say diagnostic imaging and x-rays, separate from labs, DME. Then they had some interesting detailed categories like dialysis on its own, skilled nursing, which comes into play in a big way when you get to duals and Medicare folks, home health care, and then they had a few other categories more specific to Medicaid, and then outpatient prescription drugs. So that's the gist of the template of what we were asked to populate in these various models. So let me now switch over to what data did we get, what data did we not get, and what data did we end up using in order to try to populate our projections to the best of our ability. And our projections were intended to represent the entire state of Colorado between these various membership cohorts and all the healthcare costs separated by service category. So we asked all the payers, the commercial payers in Colorado, as well as Medicare payers in Colorado, as well as HCPF for Medicaid and CHIP, to provide us with as much possible detailed data so that we could try to complete this projection. And besides the way the template is provided here, we made a modeling choice to try to be specific to the innovation. The innovation, as I think you all know, is to integrate behavioral healthcare services in primary care settings, and also to do that bi-directionally. So you would integrate primary care services in community mental health settings, and to try to do the best job we could at projecting the innovation itself. We wanted to separate all the membership populations in 4 cohorts. One, and let me go to a specific category mapping here to help show you that. So let's take the commercial business itself. You can look at these different condition groups, and what we did was to separate the commercial members into one of 4 condition groups using claim data. Group 1 was they had neither a comorbid medical, neither a chronic medical condition, and we had a whole series of chronic medical conditions plus criteria for satisfying those conditions, and I won't go into too much detail as to what that is unless people have questions. So then we also had people that had only a medical condition, only a chronic medical condition, only a behavioral condition, neither, or both. So that's what we wanted to do, and we did it this way because we thought the change factors or the innovation impact factors on medical costs would vary between the healthier people that had neither a medical or behavioral condition, those that had comorbid conditions, or those that only had a chronic medical or only had a behavioral condition. So that was our approach. We felt that that would be a better presentation to CMS and the feds of how we were doing our projection. We felt that would add credibility to our projections and add more specificity and more detail to how we were doing things rather than just lump them all together. So you can see we did that for commercial. We did that for the Medicare under 65 population, and also separately from the Medicare over 65 population, but we did not do it for the Medicaid or duals. Okay, so why was that? Well, the data we got from Medicaid and HCPF did not have the level of detail for us to look at the ICD-9s or DRGs or whatever was needed to create these 4 different buckets based on condition or condition categories. So we were not able to do that for the Medicaid population. The only thing we could do was separate out the eligibility categories. The commercial data that we used and the Medicare data that we used was of sufficient detail that we had ICD-9s and DRGs, and we could look at the various diagnostic criteria to separate out into those 4 different condition buckets, if you will. Okay, so what data did we use? Well, we asked all the payers in the state to provide us with detailed but not PHI generating claim data, as well as RX data and membership data for the commercial population and for the Medicare population. The only data that we received from the payers was from one health plan that we used, and yet that was quite insufficient to model the entire state because it was a regional plan. And we actually got no Medicare fee-for-service or Medicare Advantage data from the payers within the state in the timeline needed to be able to do the projections. So we had to look elsewhere. Fortunately, Milliman leases the TrueVen market scan data, and I am going to assume that the attendees know what that is, but it represents about 50 million covered lives nationally with commercial coverage. A lot of it is from employers and self-insured, others is from fully insured plans. So we used the Colorado data within that market, within that market scan database as a starting point for the commercial data, combine that with the one payer that provided commercial data, and then what we had to do was extrapolate that data to get the membership to line up with U.S. Census data, Kaiser Family Foundation data as to what the commercial membership in 2012, which was our base year, was to look like. So that's where we got our commercial data. And then for Medicare, since we had market scan does not include Medicare data, we went to the government's provided Medicare 5% sample file to generate the Medicare data. And again, we had to extrapolate that up to get the right starting point to represent the census data for Colorado for Medicare, aged, disabled, duals, etc. So that's where the data came from. On a go-forward basis, I would love, and I'm sure Ben and everybody else involved would love to get a complete set of Colorado payer data, and that's our ask as we go forward, as we try to hopefully implement SIM when the feds give us something hopefully close to the $60 million we asked for the State Innovation Grant in the modeling efforts. But we would love to get your partnership in figuring out how to actually implement what we have proposed in the innovation model. So let me show you a few other things. Let me pause. Are there any questions so far that I should respond to? Ben?
Yeah, Steve, up until now, we do not have any questions. And just to remind folks, on the right-hand side of your screen, you likely see a toolbar. You can put some questions in there, or you can simply chat to myself or Emma Gilchrist, and we can forward those on to Steve. Or you can also alternatively raise your hand, which if you know what that means, you'll know which button to push. So no questions yet, Steve.
Okay, great. Well, I will continue on. As in any type of financial and actuarial projections, the typical approach is to get the most recent baseline year, as long as it's credible, and use that as your launching period for the projections. And to take you back again to a sample in Table 2A, they have a cost year 0, which is really, in their terminology, the baseline year, and then they want to project the model years. So that's what we had to do, is develop our best estimate of the baseline period and then develop trend assumptions for utilization trends, average unit cost trends, membership trends because the membership of the population in Colorado is changing year by year. And then we had a few other things we had to do, which included change factors or the innovation impact factors on utilization, on costs, as well as participation assumptions, because we will be asking primary care practices and community mental health practices to participate, and we fully do not expect everybody to say, count me in the very first model year, nor will we be ready to count the entire state in the first model year. We have to figure out who to approach right from the get-go in model year 1, and more to add in model year 2, 3, 4, and 5. And since I just went there first, I'm going to show you the assumptions that we made for participation. And these are probably overly optimistic, but it helped us generate a nicer savings to present to the feds and an ROI result, which was in our sweet spot, which was not too optimistic nor too low. So what we ultimately modeled here was that in model year 1, and let me back up a little bit, we have 2 interim years from our baseline year. So our baseline year was 2012. Interim year 1 is 2013, and ignore the numbers that are in here because they don't get used at all in these 2 columns. Interim year 2 would be calendar year 2014, where we're at right now, but the model years, we would assume that year 1 of funding is calendar year 2015, and model year 2 is 2016, model year 3 is 2017, and they also asked us to project out 5 years. So you can see we ramp up from 50% of all the membership in Colorado in year 1. CMS required us to get to 80% by model year 3, and because they asked for an ROI through model year 5, we continued ratcheting up in small measures to model year 5 that we would have actually 90% of the state covered by model year 5. Is this the right series of assumptions? Probably not, but that's what we use for developing the projections. It might be a little bit too rosy. We might end up having a bigger ramp up instead of from 50% to something like 25 or 30% in year 1, et cetera, and we will revise our projections accordingly. Some of the simpler assumptions, but assumptions we still had to make, had to do with utilization trends. Again, we're at 2012 is our baseline period, and we have to project through the results of the 3 years of the funding for the implement this state model. So we had to have for again, let me summarize. We had, while 2012 was our base year for all populations, the most recent year of data we had from Market Scan was 2011. So that's why you see a utilization trend from 2011 to the base period in our assumed future trend rates for utilization. And then we had 2 years for to go from base to interim year 1, interim year 2, and then we have these 5 years of projection trends from interim year 2 to get to the 5 years on the model. And you can see, just like in the template, we have the same service categories, and just like I was showing you in the category mappings, these are the various different groups that we developed separate annual utilization rate trends for, separate unit cost trends, and separate change factors, and the biggest change factor impacts, as I said before, are in the comorbid, chronic, medical, behavioral condition categories, and the simplest change factors are on the healthy people, where there's really not much we're going to be doing with them because they have neither a chronic, medical, or behavioral condition. Ultimately, we have to roll these condition categories together because that level of detail is not provided in any of these tables in the templates. So part of our work is to roll everything together once we've developed these detailed trend assumptions. And you can barely make them out over here in column A, but these are like lookup factors, so we can look up within our tables the right trend assumptions to use. And we develop annual utilization trends, and you can see they don't really vary by year because we don't think we're smart enough to project different yearly rates into the future when we're 7 years out. But they do vary by service category, and you will note if you went through all these details, they also vary by the different condition categories that we go through. So we've got all these annual trend rates for utilization, and we have a similar set of trend rates for unit costs. And again, they rarely, if ever, vary by year, but they do vary by service category, and at times they also vary as we page down. And if I was to page down, you go through all these different condition categories for the commercial chronic medical, commercial behavioral, and the commercial, the different categories that we show, where D is the comorbid categories. So it's I show you this because there's just lots of detailed assumptions that we had to develop to vary by year, by type of assumption, and by condition category. We also had membership trends, and some of these might look a little bit wacky to you, but let's start with model year 1 through 5. Those are very flat, and they're very reasonable, I think, as far as population changes. The Medicaid and Medicare populations are growing a little bit faster than the commercial, and let me comment as to why we have some very large numbers between 2011 and the base period. As I told you before, we had to use the Colorado market scan data and then compare that to the Colorado census data, and market scan very much underrepresents the total Colorado population, and the Medicare fee-for-sample does the same thing. So to get it to a reasonable Colorado population 2012 number, we had to really extrapolate that starting point. And again, I'll call for your help in providing payer-specific data within Colorado. While we believe the market scan and the 5% sample file are fine representatives on a per member basis, the membership is grossly understated for the entire state of Colorado. So that's why we really need and want your help as we go forward to be able to access in a proper fashion without PHI your payer data so that we don't have to multiply by 972% or 2,146% to get to 2012 results that are consistent with the census data from the Census Bureau and the breakouts that we get from Kaiser that are very helpful.
Steve?
And I already talked about the population assumptions we had to make. So the final set of detailed assumptions we had to make are what I call the change factors. What are the estimated impact of our innovation on the average charge levels? And you can see we don't make a lot of changes on average charge levels, In some cases, we think we can reduce costs by using different types of providers or more use of generics for both physical and behavioral health care than might have been prescribed historically. So there's not a lot of change in the average unit cost factors, but the other really where the rubber hits the road is the change factors on utilization levels. And that's where we get to the biggest impact in model year 1, and then we tend to add smaller and smaller change factors, but these are multiplicative. So if you get, or I should say additive, if we can reduce behavioral inpatient utilization by 2% in model year 1, another 1% in year 2, et cetera, you can see how we ramp those down. And some of the changes are actually increases in utilization, increases in primary care costs, increases in behavioral specialty costs, et cetera. And this is where the change factors actually change as you go from no condition to a chronic medical condition to a behavioral health care condition to the comorbid conditions. So if anyone's certainly interested in getting a copy of the model and looking at it more closely, I'm happy to provide this. But this is where we had a lot of discussion between Ben and his colleagues, primary care colleagues, et cetera, of what do we really think the state innovation model is going to do. And it has the biggest impact in the category Ds, which are the comorbid categories, and that's where we really get most of our savings from. So let me just, now that I've talked about all the various assumptions, to show you really the summary of the end results. And you can see here, again, going to the template, Table 4A presents over the 3-year model period the savings, and again, this is the government template, so we follow these major service categories, which is much more of a rolled up categories than you saw before in the more detailed. But here is a 3-year net savings after the innovation is projected out, both on a total 3-year period, and you can see that these service categories match up in the totals, and then showing it by per member per month. And again, as is consistent with the rest of the tabs, it's by cohort. So you can see we've got almost $10 million of savings for Medicaid adults, $1 million for Medicaid kids, small amount for Medicaid duals because the Medicare costs are the highest cost for there, 25 million plus in the disabled and elderly without duals. And then below this, we've got the 5-year projections as well as the 3-year projections. A lot of money saved in the commercial sector, $77 million through the 3 years. And as we continue going across, Medicare duals, 19 million, Medicare fee-for-service, 40 million. And when you roll all that up into Table 4B, this is where the ROI calculation hits. We're asking for $60 million over a 3-year period, although we project savings going beyond 3 years as this model gets more and more self-sustaining. 3 years of savings on a gross basis of $173 million, and that ROI is 1.89 on a net basis. So this ROI is net as we add in all the savings together. You can see we almost save 3 times what we're asking, and the net ROI is 1.89. And going through 5 years, we're projecting to save $331 million, and that's a very nice ROI through 5 years. So I know I kind of went through fairly quickly the various different aspects of the model, the template that the government required us to complete, our methodology for where did we get data, how did we use that data, what were the various different assumptions that were necessary to trend from the baseline period of 2011 or 2012 all the way through the 3 or 5 years of the model. And we've got utilization trends, average unit cost trends, population trends, participation assumptions, as I showed you before, on how we're going to ramp this up for the various participation of the practices as we go forward, as well as the change factor trends that we walk through fairly quickly, and they're all available for you to look at on a detailed level as you would like. So I'm going to stop there and leave the last 15 minutes for questions to be asked and discussion to be had.
Great.
Ben?
Thank you so much, Steve. Wonderful job going over some pretty complicated information. We've had a few questions come in already, and I realize that it's going to be difficult to have a dialogue with everyone muted, so if we do need to unmute lines to have more of a formal discussion, that is possible. But Steve, let me start with a question that I know some of us went into great detail discussing, and it was around the use of the all-payer claims database. One of the questions was specifically around, did we have access to the APCD? And so while I know some of the conversations that we had on the APCD, do you want to just take a minute and explain some of the decisions that went into not necessarily using the APCD, at least at this point in time?
Sure. I guess there are a couple different factors that contribute to why we did not, during the time of the analysis, use the APCD. Certain population cohorts, this is my limited understanding anyway, would have been clean to use in the APCD, but certain categories also were underrepresented. So I think there were pros and cons of the APCD. And then the other issue is we were waiting and holding out hope that we would actually get all the payers and HCPF to provide detailed commercial data, detailed Medicare and Medicaid data. So we were holding out for that until really we couldn't hold out any longer. And then for Milliman, we know and have used many times the detailed market scan data. We know it inside and out. We also know the Medicare 5% sample size file inside and out. And there would have been a learning curve that I would not say was small on how to use the APCD, because we have never used it before. And part of our concern was, would we get it done in time? And also, we still need to use other sources to fill in the gaps in the APCD. So we just made the decision at the time to go ahead and use databases that we were most familiar with, so that we didn't misuse data that we'd never used before. And I hope that's an adequate answer to the question.
Yeah, very helpful, Steve. Thank you so much. Another question that we had was, does this ROI projection include other costs of the program, such as different payment models?
That's a good question. And so this is, I think of this projection as a macro level, statewide, real big picture projection of what we think could happen under our innovation model. When we implement it, let's assume we get hopefully $50–60 million from CMMI. We have to figure out what to do with that money and how to roll it out across the state. and how to use different databases to try to develop the details of payment model reforms. And those payment model reforms could be a combination of using some of this money to hire, to enable primary care providers to hire behavioral professionals, or bidirectionally the other way around, to be able to use some of this money to develop what I'll call, and these are suggestions, what I'll call enhanced primary care capitation rates. And the enhancement would include primary physical care, primary behavioral care, care managers, teleservices, etc. So a big bucket of services to be encompassed within a primary care cap model, but also to set up the ability to have shared savings for what happens outside primary care. And that would be to tap into hopefully savings at facilities, savings for RX, and savings in specialty care that are outside primary care. So I think that's what we need to do as we go and as we figure out how to implement this, how to develop a payment model reform that will be interactively done with providers that will hopefully be a win-win-win for everybody, for the members, the providers, and the payers, and CMS ultimately, of a better way to do things than just continuing on the fee-for-service model.
Excellent, Steve. Thank you so much. We've got a couple more minutes for questions, so I'm going to see if anybody else has a question. But Steve, moving forward, I think you alluded to this a couple of times, recognizing that the feds are going to release the announcement for the SIM proposal, we hope any day now. And knowing what you've done so far in this last analysis, aside from some of the things you've already told us today about limitations of the model, is there anything else that you think that you actually would need or would like to have moving into the next stage of how to develop an actuarial model and analysis for the SIM project? Anything you didn't tell us already today?
Well, I think, you know, where my mind is going is that this is I think a really good projection. We spent a fair amount of time with it, both funded and our own in-kind contribution of developing this macro state level model to fit the template that the feds wanted. But implementing, going forward, what we are going to have to add is take this projection from a macro to a micro level. And what does micro look like? Well, I think it's saying, let's take PCP practice A and look at all their members and look at hopefully 3 years of historical costs for those members. And I realize that membership will be a mix of commercial members, Medicaid members, Medicare members. And if we can get 3 years of payer data to go with that, we can be very, very accurate in trying to project what the cost would be under payment model reforms, shared savings projections, et cetera, et cetera. So that's why getting to the micro level using similar types of assumptions as we've developed here, but tailor those assumptions for the PCP practice. And I realize with some practices, they'll be too small to use their own data for projection. So we will have to start pooling some of the practices together and do things differently for mental health centers and primary care, different for rural and urban and frontier and those things. But gosh, having access to detailed data so we can think about and scratch our heads and try to do the best job we can so it's not too detailed, but not too simple, so that when the feds are looking over our shoulder and watching us, and they will, assuming we get their money, and watching us implement this, that we can do the best job possible to show them that we can make this work, we can do it in an actuarially sound fashion, we can work side by side with payers and providers and evaluators, et cetera, do the best job possible so that the feds who want this to be sustainable and accurate and portable, so that we can do it well within Colorado, and then help show the rest of the country how to do the same thing we did in Colorado, so that the feds can have a program that's just not in Colorado, but they can move it and the principles we've established to pick your state, Oregon, Illinois, Florida, whatever, and to help make this a great solution, not just in Colorado, but in other places as well.
Thanks, Steve. We've got one more question, and before we ask that to you, let me just remind folks that if you were unable to watch this today, or you want to share this with colleagues, we will have this up on our YouTube channel, which I've posted the link in the questions and answers section. We'll also send out the link to this after the webinar, if those of you that want to share around that YouTube link. But it's just, if you go to YouTube/user/CUDFM policy channel, that's where the webinar will be. So Steve, I think we have time for one more question, and here it is. Is the model expected to have secondary non-healthcare benefits, such as decrease in correctional care? If so, can these non-healthcare savings be included in the submission to CMS?
Oh, another great question. And we did not incorporate any non-payer healthcare savings within our model, but I think that many or all of us would expect that if we can pull this off, if we can get people with these conditions healthier, I've heard at least a few different people say the correctional system is the largest provider of mental health care services in the U.S. And if that's true, and we can keep people out of there that have mental conditions and get them healthier, then we do have ancillary savings that we can think about how to estimate and how to communicate back to CMS that not only are we reducing healthcare costs, but we are reducing other costs within the state of Colorado that are related to what we're doing in the innovation.
Thank you, Steve. And I want to thank again all of you for joining us today. This has been very helpful, Steve, and I think those of you that were able to ask your questions, thank you for that. If you have additional questions, you can always contact us back channel, but you should see on your screen now the link to the YouTube video that we'll have probably in the next couple of days up live for you all. On this note, I just want to thank you again, Steve, for your time, and thanks to those of you that joined us today. We look forward to hearing your questions and comments at future venues. Have a wonderful afternoon, everyone.
Thank you, Ben.